Before I start, so these are my disclosures. But before I want to go into my topic itself, I wanted to tell you a little bit about HIV in India, because I'm not sure how many of you are familiar with what is happening with HIV in India. So overall, if you look at India, they say the HIV epidemic is declining, and it seems to have plateaued sometime in like 2001 or 2002, and since then it has been declining, and this is among the antenatal clinic attendees. But if you look at high-risk populations and key populations, yes, we did see a decline among heterosexual populations in India, but among female sex workers, transgenders, and people who inject drugs, we still see a significant burden of HIV in India. And if you actually look at what is happening in India today, it looks like we have sort of hit a plateau. We're not able to bring down the prevalence or the incidence of HIV among these key populations, but in the general population, we seem to have reached some kind of a control of the HIV epidemic itself. So I just want, before I go into the actual models, I want to tell you a little bit about men who have sex with men and people who inject drugs in India. So it is estimated that we have 2.35 million high-risk MSM in India. Don't ask me where these estimates come from. This is what the government says. But yes, but if you look at estimates from other studies where they've surveyed men, almost 10% of adult men in India have reported sex with another man, which actually translates to almost 50 million people. Because in India, percentages don't mean anything because we have a population of 1.3 billion. So 1% ends up being 1 million or 10 million, and 10% ends up being 100 million. So these numbers just don't make any sense when you're looking at things from an Indian perspective. And for those of you who are also aware, we had the age-old British law, the Section 377 of the Indian Penal Code, which actually said, these are the actual words, and for those of you who are also following, this law was repealed earlier this year. But repealing a law doesn't mean that it's gone and it's going to be accepted by society, but it's definitely a first step in the right direction. We think this is going to be a great step in trying to improve access to services for MSM in India, but we don't know what the repercussions of repealing a law can be. Because does that mean that more people are comfortable coming out? How is that going to be viewed as by society? So that's something only time will tell. And in terms of people who inject drugs in India, India again globally is like the largest consumer of opioids. But again, when you're looking at India, India is the largest of many things globally, just because we have so many people. And we also have like a very different drug-using epidemic in India, because we have some really old epidemics in the northeastern states of India and some very new and emerging epidemics in the north and northwestern parts of India. So for those of you who are familiar with Indian and Bollywood movies, I'm not sure if you heard of the movie called Udta Punjab, which is all about the drug use epidemic in the state of Punjab. Which is very true. It's happening and it's in your face, and people didn't like the movie because it really brought the epidemic out into a main screen in India. But just to show you where India is located, so the red and the blue on the map, so one's the golden crescent and the other is the golden triangle. So those are the two largest heroin producing regions in the world, and we have drug trafficking routes for heroin running through the country from both sides. And so as a result of this, we see a lot of old epidemics in India and the northeastern states, which is over here, and then you see a lot more new epidemics in the northern states of India, especially in Punjab. So there are a lot of similarities between the HIV epidemics among MSM and people who inject drugs in India. They both have an extremely high HIV burden. Both populations remain hidden, and stigma discrimination is extremely high among both populations, especially at healthcare settings. And the way services are delivered in India, we have a very fragmented service delivery approach. So what I mean by that is, if you want to get tested for HIV, you have to go to one particular venue. If you want to get tested for an STI, you go to a second venue. If you want opioid substitution therapy, you go to a third venue. If you want ART, you have to go to a fourth venue. That's the way the government centers, the healthcare model for India is set up for HIV right now. And none of us want to go to multiple venues. So if you think of yourself as being an MSM, or think of yourself as being a drug-using PWID, and be like, where would I want to go? Like, I would ideally want all my services at the same place. So I go to one place and I get all my services within that one facility. So this actually led us to design the study called the National Collaboration on AIDS Study, which is a cluster randomized trial, where the intervention, which was an integrated HIV prevention and treatment model, was nested between two serial cross-sectional studies. And the primary objective of the trial was really to look at whether an integrated service delivery model would improve uptake of HIV testing in India among key populations, namely men who have sex with men and people who inject drugs. I'm going to go over the study, but I think more of the presentation I want to focus on is what did we really learn from the study? So essentially, we did a baseline assessment in 27 cities. So as you can see from the map, we were literally across the country, and most of the MSM sites were in the southern parts of the country, and most of the PWID sites were in the north and northeastern parts of the country. And in each of these cities, we recruited 1,000 of that key population. It was either 1,000 MSM or 1,000 PWID, and we used respondent-driven sampling. And our eligibility criteria were very stable. For drug-using populations, we said they have to have a self-report of injection drug use for recreational purposes at least once 24 months prior to recruitment into the study. And for men who have sex with men, they had to self-identify as male and report sex with another man in the prior year. So the one thing we also did in the study, which was one of the first times we've done it with key populations in India, is we used a biometric platform to track participants, to identify duplicates. Especially when you're doing a cluster randomized trial, you want to make sure your clusters are independent. And the minute you see people crossing over between clusters, you know that you no longer can have, that the cluster is no longer pure. Like meaning that it gets contaminated. So the intervention clusters and the control clusters end up mixing together. And so your intervention is no longer purely like in the intervention site. And I can talk more about the biometric platform later. So a couple of things I want to present here is, though we talk about PWID in India as one population, it's a very different population. As you can see, the proportion of women ranged from 12% in the northeast to almost no women in Kanpur, which is in the state of Uttar Pradesh, which is right in the middle of India. And again, if you look at the type of drug injected, you go all the way from almost everyone injecting heroin to almost everyone injecting a prescription opioid. And each of these epidemics cannot be addressed using the same model, which is something we learned after we implemented the trial, and so we had to adapt as we were going on with the trial. And similarly, with men who have sex with men, a couple of things is like their age range varied depending on the city you were in, and a lot of them were also married to women. And this is something that's very common in India, where men who have sex with men get married to women to satisfy social norms. And if you can look at the median number of lifetime partners, that range from 5 to 20. So these really are, though we're looking at India as a country, each city in India or each state in India can almost be looked at as a separate country which needs its own model. So this is like our baseline findings from that respondent-driven sampling survey. So as you can see here, we saw an extremely high prevalence of HIV among people who inject drugs across the country. But what was striking was in the northeastern states, despite seeing an extremely high prevalence, we didn't see a very high incidence. And this was strongly correlated with the proportion of people who inject drugs who are on antiretroviral therapy. So it really does speak to the power of treatment as prevention. So the more people were on treatment, the less likely was the incidence going to be high in those particular cities. And we saw a similar pattern among men who have sex with men as well. The prevalence was high, but not to the same magnitude as people who inject drugs. And again, cities with the highest prevalence did not necessarily have the highest incidence, and it tracked really well with where access to therapy was the best. And this is what the care continuum looked like among people who injected drugs when we started and MSM when we started the program. About 40% of them were aware of their status, and the care continuum really did trickle down, and we were very far from achieving the 90-90-90 targets among men who have sex with men and people who injected drugs in India. So the next step was to randomize. So for those of you who are interested in the randomization procedure, we used a restricted stratified approach. The two strata were MSM strata and the IDU strata, and the restrictions were all based on the primary outcome. The only condition we had, when you're working with the Indian government, you do have to adjust, you have to give in to whatever their requirements are. So one of their requirements was all the ICCs cannot be in the northeastern parts of India. So we did put a restriction in there saying no more than 3 intervention sites will be in the northeastern parts of India. The other clinics could be anywhere else in the country. And this was what the final ended up to be. And so as you can see, we did end up with 3 ICCs in the northeastern parts. And again, what I want to point out here is it was literally across the country. So this was a similar model that had to be tweaked a little bit in each setting depending on what the population and the needs were in that particular city. But it was a model that was implemented across the country itself. And the next step was actually establishing these integrated care centers. So what were these integrated care centers? For MSM, we built it along the HIV counseling and testing centers. So we essentially took HIV counseling and testing centers and scaled them up to provide all the other services MSM would need. So we included general medical care, we included condoms, counseling, Antiretroviral therapy, we either had it available on-site or we had a link model where they would go, where a peer navigator would accompany them to the government ART center, get them initiated on antiretroviral therapy, and subsequent refills, our outreach workers would collect them and hand them off to the participant itself. So we were working with a model that was already in place. We weren't trying to recreate the model from scratch. Essentially, what we were doing was we were taking services that were already available and just repackaging the services so that they were all available in a single window model. And what was striking was like the staffing. So we didn't have, it wasn't very staff intensive. So we had one site coordinator who managed all the day-to-day operations and the biometric platform. We had one nurse who managed the STI treatment, the TB screening, the TB treatment. We had one doctor who managed the general medical care, the HIV care, and ARV prescription, answering questions about side effects with antiretroviral therapy. We had one counselor and multiple outreach workers, depending on the strength of the clinic. So this is what a typical ICC looked like. So this was the phlebotomist drawing blood. This was the site coordinator. These are the waiting areas, and that's like the counseling room. So they really were bare bones structure. It cost us about $1,500 to run every month. So it really was not that expensive implementing this model in India. And across this model, over the 2-year period that this model ran, we saw 21,949 unique visits into these clinics. So all these numbers come from biometric data, so it is really 21,949. We may have missed some, so there may have actually been more visits. We saw about 8,500 unique MSM across these 5 different clinics, out of whom 7,000 were offered HIV tests. We newly identified 350 MSM, and about 1,300 existing HIV positive MSM linked with us for the antiretroviral therapy services. And for the ICCs, for the people who inject drugs, it was a similar model, except instead of HIV counseling and testing, the opioid substitution therapy, the OST center was the center of that model. Because OST really is one of those services that draws drug users into a model. So when they came into the OST center, what we did was we offered them HIV counseling and testing, we offered them antiretroviral therapy linkage or on-site, TB testing and treatment, general medical care, STI testing, condoms. So essentially it was the exact same thing as the MSM, except instead of running the model separately, we ran everything out of the OST center. And again, it was very minimal staffing. The only thing we did differently here was we had 2 nurses, one nurse who was dedicated to opioid substitution therapy, because some of these clinics saw 700 unique clients every day. And one nurse had to deal with all the 700 clients. So they would walk in, put their fingerprint. The minute their fingerprint gets logged into the system, their dose would automatically pop up. The nurse would dispense the dose, mark their attendance as given, and out. So it really was like a 1 or 2 minute process in which people were walking in and out of the clinic for opioid substitution therapy. So this is an example of a ICC within an NGO setting, in a non-governmental organization setting. So that little thing in her hand is where we crush the buprenorphine before we put it under people's tongues. I don't know if you've seen this before, but when you're dealing with buprenorphine tablets, if you give them the tablets, they can divert it and inject it, so they actually crush the tablets in a little thistle and they put it under people's tongues. And this is a nurse who's managing the STI testing, and that's the chart which the government of India uses to dispense STI treatment, a counselor in a clinician room. And this is the same thing. This was the site of Ludhiana, which is in Punjab. So this site essentially saw 650 clients every day. And so as you would expect, across these 6 clinics, we registered about 11,000 people who inject drugs. About 7,630 were tested for HIV, out of which 420 were newly diagnosed. In addition to the 7,600, we also registered about 2,400 HIV positive PVID who were previously engaged in care somewhere else but came into the center to use our services to pick up antiretroviral therapy. And what is also striking was out of the 5,263 HIV tests for hepatitis C we did, almost half were antibody positive. And so compared to the MSM, where we saw 21,000 visits, among the IDU clinics, we saw 706,798 unique visits. And so all this was again done with that minimal staffing protocol in place. And we also did do a client satisfaction survey, and we all kept adapting our model depending on what clients said. If they didn't like some of the staff, we went and spoke to the staff. And if they still didn't like the staff, then we were like, well, we have to let the staff go. So there was an ongoing feedback from the community. So the community really did play a key role in the implementation of the model. And that's something we did learn along the way, is you have to keep your community involved. And so these client satisfaction surveys did really help us understand what they liked, what they didn't like, and also what extra service or what additional services they would want to see delivered at these venues. So again, to point out, in the usual care, all the services that we were providing in the ICCs were already available, except they were available at different venues. They were not available at one single one-stop shop model. So these clinics ran approximately for 2 years, following which we did an evaluation assessment, which was again the exact same thing as the baseline assessment, where we did RDS samples of all the different sites. And so what we essentially did was we compared a snapshot of what was happening in the communities at baseline with a snapshot of what was happening in the communities at the evaluation. So you're essentially comparing two snapshots. So we never followed a cohort, which is common in many studies where you follow cohorts across the studies. But what we were really looking at is how did these clinics really impact events at the community level, and not within subsets of people who are enrolled into cohorts in these communities. So this slide is a little confusing. I'll try and walk you through it. So on the left, the India map is the usual care sites, and on the right, it's the ICC sites. The green arrows show a positive change showing that we did improve HIV testing, and the red arrows show a negative change saying that we reduced HIV testing went down between the baseline and the evaluation surveys. And the height of the arrows, whether vertically going up or down, shows you the magnitude of the change. So as you can see, like for the large part at the ICC sites, we seem to have seen a better change, with the exception of Dimapur and Aizawl in the northeastern parts of the city. Overall, we saw an 8% increase, but this did not meet statistical significance at a P of 0.05. The confidence interval ranged from -0.1 to 17, and we did see a much stronger benefit among people who inject drugs compared to men who have sex with men. So I'll talk a little bit more about this, but before we go into the finer details, so we also looked at the other care continuum outcomes. So this again is looking at community level change. So this is essentially looking at everybody who was captured in the evaluation survey and the baseline survey, regardless of whether they actually accessed the ICC or they didn't access the ICC. So as you can see here, there was a 31% relative increase in HIV testing, but we didn't seem to have impacted awareness of status, initiation of antiretroviral therapy, or viral suppression at the community level. So now if you say, okay, let's look at the individual level, and let's look only at the individuals who went to the ICC versus the individuals who didn't go to the ICC, did we have any impact there? So if you restrict the analysis only to the individuals who went to the ICC, we saw almost a 3.5 times higher likelihood of HIV testing. We saw a 1.4 times higher likelihood of awareness. We also saw a higher likelihood of initiation of antiretroviral therapy. So it really does show you that these ICC models work as long as you can get people to go into the ICCs. And so a lot of the lessons we learned was the community level outcomes, we measure them regardless of whether people were going to be enrolled in the surveys, enrolled in the ICC, or not enrolled in the ICC. We didn't really account for the size of these cities and the size of the underlying population when we were planning these studies. And what it essentially comes down to is that your community level impact is a factor of two things. The first factor is how effective or how efficacious is the intervention, and what proportion of the community do you reach by the intervention. And unfortunately, we ended up reaching a lot less than what we really expected. And so then we did a post-hoc analysis looking at what was the interaction between coverage. So essentially what we did here was, because of the biometric platform, we were able to accurately estimate what proportion of people in the evaluation survey had actually been to the ICC. So we know that in the triangle all the way in the bottom, it was less than 15% had been to the ICC. We didn't see much of an impact. But as the coverage improved, or as we started reaching more and more of the population, the impact of the intervention on testing started going higher and higher. And so it's clear that once the penetration exceeded 35%, you saw a very strong association between going to an ICC and improving HIV testing and counseling. And I just want to take the example of this one site here, which has like a 52% exposure. So that actually happens to be the city of Imphal, which is in the northeastern part of India. It was a truly community-based model. So we had 3 different ICCs in Imphal, whereas in all the other cities, we only had 1. There were logistical issues. There were a lot of I don't know how many of you have been to the northeastern parts of India, but it's not the safest part of India to be in. It seems like a war zone. Every time you go there, there are always people sitting on tanks. There is like an army curfew, so people can't go out in the evenings. So it really was one of those cities where we couldn't get access to everybody. And so when we spoke to the state AIDS control societies, the National AIDS Control Organization, they said, scale up all the 3 different NGOs there, make sure all 3 of them are ICCs. So we actually ended up having 3 ICCs. We covered almost 55% of all the people who injected drugs in Imphal based on the estimates available at that point in time. They were also one of the older epidemics, so stronger advocacy groups. The government was also more willing to buy into the program in the northeastern parts because that's where they saw drug use as being a big challenge. So this is what the awareness was in 2013 before we did the epidemic, and this is what it looked like in 2017. So it really does show that if you could penetrate the community hard, sufficiently and improve access to testing and improve access to care and come up with a true community model, you really could impact the 1990 targets. And what we also learned while we were doing is, especially in the northeastern states, for them HIV was not a big concern. For them hepatitis C testing was a bigger concern because more of the HIV-infected drug users or HIV-infected people in the northeastern states were all dying of hepatitis C. And so they said, is there some way of incorporating hepatitis C testing into this program? So we actually incorporated hepatitis C testing into this program in 2015. And if you look at our outcomes for hepatitis C, you can see massive increases. Because compared to HIV, where we were starting with a baseline of 41%, for hepatitis C, we were starting with a baseline of 6% of testing. Right? So you were starting off from a much lower place, and so you had so much more ground to gain. And so we actually did end up seeing significant improvements in HIV testing by integrating hepatitis C testing into an HIV care model. So it really does show that integrating multiple health systems is possible, and it actually should be done because you have to be addressing multiple health issues at the same time. And we cannot be siloed and just saying, we will take care of HIV, someone else will take care of the hepatitis C, someone else will take care of the TB. But I think the most important thing is all the lessons we learn. So we always do a study trying to answer a question, but most of the times when we do the study, like 100 different questions come up. Right? So I think that's where the study really was interesting to us. And I think the first thing we learned was the epidemics were very diverse. So I showed you what it looked like in 2013, and this is what it looked like in 2016. So Delhi, which is the capital city of India, had like the highest incidence among PVID. We had an 18.5 per 100 person years. So this is a cross-sectional incidence based on a multi-assay algorithm. And the only city in the northeast which had an extremely high incidence among PVID was Aizawl in Mizoram, which was also, if you remember the map with the HIV testing, that was also the only city where we saw a massive decline in the uptake of HIV testing. So the problem is, when you're doing RDS-based surveys, it captures exactly what is happening at the community at that point in time. And that doesn't necessarily reflect who went to the ICC, who didn't go to the ICC. So I think what essentially happened was Aizawl was also one of those cities where we saw the minimal overlap between the population that was in the RDS2, the evaluation assessment, versus the ICC. So it really does show that RDS may not be the best in terms of capturing outcomes for a clinical trial. You may need something more than RDS going forward. And it's the same thing we also saw with MSM. Again, places with extremely high prevalence like Vijayawada didn't have an extremely high incidence. Again, very strongly correlated with antiretroviral therapy uptake, viral suppression among HIV positives. So the higher the viral suppression among HIV positives, the lower the HIV incidence. So this really does make us question our approaches, especially among key populations where we don't have good measures of incidence, is how do we measure program effectiveness? How do we measure which communities and which cities are ideal for PrEP? For PrEP, the guidance generally is we need an incidence of greater than 3%. But if you look at these maps, like none of these cities in India actually match the guidance, the WHO guidance of greater than 3% incidence for PrEP. So it may be more relevant to start looking at subpopulations within these populations to try and see, are there specific subgroups where it would be more cost effective? Again, I'm talking more from a programmatic perspective. From an individual perspective, I think everybody who needs PrEP should get PrEP. But every time I talk to the Indian government, the question always is, You say it so easily, but you have to understand, if I need to invest for PrEP, I have to invest for 1 billion people. So it's not as easy as like, okay, let's add PrEP to the program. It ends up being a significant investment when you start looking at things from a programmatic perspective. So the other thing we also learned clearly was just putting up these clinics was not enough. Putting up these clinics needs to be complemented with demand generation strategies. So we are actually currently extending this trial, and we learned a couple of lessons. So we are going to be incentivizing pre-ART retention, ART initiation, ART refills, and motivational counseling. We did think about incentivizing viral suppression. Unfortunately, viral load testing is not routinely performed as part of the program, and we decided to go with components that we could incentivize that were already being delivered as part of the program. And also, given our lesson learned from the RDS, we will also have cohorts in place this time in addition to the RDS sample. So the cohorts will look at viral suppression in a subset of participants in these intervention versus control communities, whereas the RDS samples in the baseline and evaluation will look at viral suppression in the community itself as a whole, and what was the change in viral suppression from before the incentives to after the incentives. And a lot of the impetus for the incentivization comes from a trial we actually did in India, which showed that just giving them small incentives, it was like 150 rupees, which is about $2, which is really nothing. And the reason we came up, so all of this actually stems from a lot of discussions I've had with the patients in the field. And I was like, why do you guys not want to go to the government centers? Like, what is your problem? And so they said, most of us are daily wage earners. If we go to a government center, we lose our daily wages. We have no income, we have children, we have families at home. So how do you want us to support them if we go to a government hospital and end up spending the whole day there? So we said, okay, so what if we actually substitute you that amount? We'll give it to you in the form of non-monetary gifts. We'll give you rice, we'll give you dal, we'll give you toothpaste, we'll give you blankets. Will that make you go to the government hospitals? So as you can see, we had like almost 3 times higher likelihood of people starting ART when we told them we will give you these incentives. And so what happened as a result of this was like the families got very engaged because these people would go back home with like rice, dal, and different things that they could use for the house, that they were actually forcing their husbands to start going into these clinics for antiretroviral therapy. So the other thing we learned from this study, which I think is really important and has implications in many settings, is that networks can be leveraged. And you can actually use these networks to identify infected and unaware individuals. So what I really want to show you here is how RDS worked in one city and what I really mean by leveraging networks. So we all know that RDS is an intervention that's always used for surveillance. So to give you an idea of how RDS works, you always talk to the community, find 1 or 2 people who are considered key community opinion leaders, and you start the RDS process with them. And they are called the seeds, the really well-connected people in the community. So here we have 2 people who are the 2 seeds. We gave each of them 2 coupons and said, go out, give it at random to any 2 people in your drug-using network and have them come into the study. When they come into the study, you will get an incentive when they come in, and they will also get compensated for their study time. And so they would recruit 2 people, and that would be considered wave 1. And when they come in, you would repeat the process, give them 2 coupons, and that would be wave 2. And in this process, the sample just ends up recruiting itself, and with minimal interference, no outreach staff. Right? And so in Kanpur, in 131 days, we recruited 1,000 people who inject drugs. Right? And as you can see from the sea of like yellow, orange, and maroon, a lot of HIV and hepatitis C. But what was even more striking was the people who were unaware of their status. Almost 97% of all the HIV-infected PVID were unaware of their status, and 100% of 684 PVID who were hepatitis C infected were unaware of their status. So we always use RDS for surveillance, but this really shows you that RDS could be leveraged beyond just surveillance. Could we be using network referrals as and incentivizing network referrals as a strategy to start finding populations? The other thing we also learned was, for all of you who've been to Chennai, you know in Chennai distances are very short, but we never measure distances by actual distance, but it's more measured by time, because from point A to point B may only be 100 meters, but it could take as little as 10 minutes, but as much as half an hour. So we always look at time. And so if you look at how the recruitment happens, so the star is the site in Chennai, And that little yellow there is where one seed came, and this yellow here is where the second seed came. And so by the time we went through the first 5, it pretty much spread across the city. And by the time we had the entire sample, it had literally mushroomed across the city. So not only was it reaching a lot of people, but it was reaching a lot of people from great distances across the city. So we actually had a student from UCSD who was doing his MPH in India, MPH with me at Hopkins. We were trying to figure out is that can we use this spatial data to try and figure out how do we target programming? And so what we were able to do is we were able to actually plot on a map the different zones of the city where MSM lived, and where do HIV positive MSM live, and where are the most viremic MSM live. Right? So this can literally serve as a guide as to how we should be targeting your interventions. Like if you look at the first map, you would say, okay, let's target this area. But if you're really looking at avoiding transmission and you have limited funds, we really should be targeting this area, zone 2, which is a small area where there's more than 100 HIV-infected HIV viremic MSM. And the reason we went with absolute numbers is because, again, as I mentioned in India, like prevalences and percentages don't really mean much. So when you have absolute numbers, you actually have a goal and a target as to what we should be looking for. So we know like in this region, we should be looking at least for 100 MSM who are viremic. And this is from our survey data. So this is something that can be easily leveraged. And so we are actually evaluating the strategy right now is if we can do an RDS, collect the data from the RDS to create spatial maps of the city where HIV prevalence is the highest, and then use those maps to target where we do field-based testing and where we do community-based testing. Because again, at the end of the day, the goal really is how do we make programs cost-effective? So the other thing we also learned was, all of you who have studied RDS know that you have to hit equilibrium, which is like your prevalence plateaus after a particular number of waves, which is what you see here. So overall, the HIV prevalence plateaued somewhere between around 18%. But then if you start looking at the subset of HIV positives, you see that as you go deeper and deeper, further and further into the waves and deeper into the community, the prevalence of people who are unaware of their status keeps going up. And this is the same thing with viremic individuals as well. Like initially, you start tapping into the very well-connected people who are more likely to be engaged in care. But as you start going further and further into the community, you start tapping into these networks that have not been previously leveraged. And so a lot of them come out who have never been in care and who end up being viremic. So it really does show. So this is another strategy we are evaluating right now is, can we just let RDS run for a year or for 2 years? Because in India, the guidelines are like each key population has to be tested every year. So we're actually just letting RDS run for 1 year in 2 cities, in Varanasi and in Morinda in Punjab, just to see how many people do we reach and can we actually start finding more and more infected people. I know in Morinda, which is estimated to have 600 PVID, we've already recruited 1,700 and it's still running. So we also know like the numbers that the government comes up with, we really don't know what the bases are for these numbers. And the most important thing, I guess, is the cost efficiency. Whenever you're looking at a program and whenever we talk to the government of India saying that we have to pay people to come in, they're like, oh, we can't pay them. That's not part of the government where we pay people to come in for testing. So we actually show them how much it costs. So the cost of RDS itself, just running the RDS experiment in Kanpur was 14,000 rupees. So that's including staff time, laptops, the biometric scanners, the surveys, the rent, electricity. And the cost of HIV testing, we used US $3, which is the market rate, but it's actually available for $1 a test. But just to be conservative, we took the higher rate available in India. So we estimated that to be 3,000. So it cost us roughly $40 to find one person who was unaware in Kanpur, which really is nothing. And if you look at the cost of adding hepatitis C into that same program, and we again used the market rate of $4.5, it cost us an additional $7 to find one person who was hepatitis C virus infected in Kanpur. So it really does show you that leveraging existing programs to layer on multiple programs, whether it's HIV, TB, or HIV viral hepatitis, really does have a big bang for your buck, because your biggest challenge really is finding that person. But once you find that person, whether it's an MSM or TG or FSW or PVID, test him for every infection he's probably at risk for. But unfortunately, that's not how programs work. We have like a separate vertical for an HIV program, we have a separate for a TB program, a separate for a viral hepatitis program, and each of them, and they don't speak to each other, and most of them run their own programs independently, so it ends up being a lot more expensive than it needs to be. And if you look at it in another way, again, it was completely driven by HIV prevalence, how much it cost us. And this big circle in the middle, 5636, was the city of Chennai, where we are based. So I don't know if that means we're doing a good job or what really is happening in Chennai, but that ended up being the most expensive city to find one person who was HIV unaware of their status. And again, if you integrated the hepatitis C, the median cost to integrate to identify one unaware infection was $10. So it really does tell you we should be integrating multiple programs into one, which really hasn't happened yet, but we should be thinking of it more from a policy standpoint. And this brings us to the other question, then if everyone is interconnected, then how do you define a network? Because we keep talking about network-based prevention, network-based treatment, but then how really can we define a network if the RDS network just went and recruited the entire city at one shot? So we actually randomly selected a random sample of sequences from Amritsar, Delhi, Kanpur, and Imphal for hepatitis C sequencing, and we identified clusters with a posterior support of 70% and a genetic distance of 4.5%. And this was actually done by one of my PhD students, and he used machine learning to identify factors that were associated with clustering to try and figure out what really is associated with clustering. So this is pretty much what he ended up with, and I know it's a little complicated. For some of you here, it probably makes a lot of sense, but for some of you here, it probably doesn't make any sense. But I'll try and walk you through this. So all these colors essentially mean that they are all part of one cluster. And the tips, like these little circles here, whether it's Amritsar, Delhi, Kanpur, and Imphal, each of those tips is a different color. So a couple of things I wanted to point here is out of the 486 sequences, 251 clustered with one another. There were only 8 dyads, which means there were only like 2 in that particular cluster. There were 6 clusters that had more than 10 people, and the median cluster size was 7.4. But what was very interesting was if you look at this one cluster, you see both red and black tips there, which essentially means we had sequences from both Kanpur and Delhi clustering together in that same cluster. And similarly, if you look at this cluster here, between the red and the blue and the black, you have Amritsar, Delhi, and Kanpur falling into the same cluster. It really does tell you that there is a lot of mobility, a lot of migration, and sequences are traveling across the country. So it really does not clearly answer where should the cluster end and where does the network begin. It really does make it a lot more complicated, and almost makes sense that networks should rather be defined by space or places rather than by who do you currently inject with. And so to answer this question, we're actually implementing this study, which I just want to share some preliminary data with you on. So Sanjay is actually going to be working with us on this, on the analysis here. So we're trying to start this study called the spatial network. We were really going for the social network, but unfortunately the name was taken. And so we had to settle for the spatial. And so the goal here really is to identify individual, network, and spatial drivers of HIV epidemics. So what we're trying to do here is to understand the overlap between different types of networks and what is the most relevant network for transmission and what is the most relevant network for interruption of transmission. So just to explain what these networks mean, so let's consider these 3 individuals. And so and he says, I inject with these 3 people, so that would be considered as egocentric network, and those 3 individuals did not inject with anybody else, so that would also be his sociometric network. So for this individual, he says he or she says she injects with these 3 people, that would be their egocentric, but each of these 3 people injects with more people, and that ends up being their sociometric network. So they're no longer just that individual network, but they're part of a much bigger network. And though this person is not injecting with this person, he's at risk of infection from that person through that connection. And then you have another case where you have an even bigger network, right? So that's a different example of where the egocentric and the sociometric network is, where this person is no longer even in the middle of that network. He's gone to some periphery of the network. But then what we have also seen a lot is people generally end up injecting with people because of the place where they inject rather than who they know or who they don't know. So for example, if this person shows up at a particular venue where he injects with these 3 people and all 3 of them are not there, what is he going to do? He's probably going to find someone else in that same shooting gallery or that same venue who's also injecting and inject with them. So we've actually also trying to characterize the spatial network, which is characterizing the different hotspots. So we have latitudes and longitudes of the different hotspots in Delhi where people inject and asking them to tell us which are these different hotspots where you inject. So we're essentially, we have self-reported egocentric, self-reported sociometric, and we have self-reported spatial networks, which is like an extra dimension. And we're going to overlay all this with phylogenetic networks. So we will have full-length sequences of HIV and Hep C, and if you assume that is the truth, it really is going to tell you where is all this transmission happening. Is it relevant to the egocentric? Is it more the sociometric? Or is it all driven by space? I just want to give you some quick data. So as of 26 November, we recruited 1,900, almost 2,000 participants as of today, using just 8 index seeds. And remember, this is not an RDS sample. We're recruiting only injection networks. So they actually have to describe the person whom they're going to give the coupon to, give us like a name, give us like some distinguishing mark, either a phone number, and only that person will be recruited into the study. So just the injection networks, we recruited close to 2,000 people using 8 index seeds. The baseline HIV prevalence was like 37%, the baseline hepatitis C prevalence was 66%, less than 10% were virologically suppressed. And as we've just started our 6-month follow-up, and out of the 169 who were negative at baseline, 24 were newly infected, which is translating to an incidence closer to like 28 per 100 person years, which is probably higher than what it is in sub-Saharan Africa currently. So though we say in India the prevalence is going down, it's going down overall in the country, but there are pockets within the country where we see exploding HIV epidemics. And this is something that we should consider and not treat a country based on summary statistics, but really look at individual city-level data or community-level data to try and figure out really what is happening in the communities and where are the actual points where you can intervene. And similarly, for hepatitis C, the incidence is close to 38 per 100 person years. Again, an extremely high incidence of hepatitis C in a setting where we should not be seeing too much of hepatitis C or HIV. And so we actually went to figure out what was going on and how are these networks. And this is what a typical shooting gallery in India looked like. So remember that one index network where I told you the network size is almost 900 people? This is where it was. So this was on the banks of the river Yamuna. As on average, at any given point of the day, there's at least 300 to 400 people who inject drugs here. And totally over the span of the day, at least 1,000 unique drug users rotate through this venue. Speaking to a lot of the PVID in Delhi, they said every PVID in Delhi at some point of time has rotated through this place. A lot of migrant laborers here from Punjab, from Uttar Pradesh, from Delhi, which completely explains why we're seeing intercity clustering, because all of them seem to be coming in and out of the same place. So it really does make sense, but I think until we actually went to this place and saw it and said, okay, now that network size of like a 900 people makes sense, because it just didn't make sense. Like, how can one injection network be that large? But when you go there, you see everybody injecting with everybody else, that it made complete sense. So I guess in conclusion, I must say India has made dramatic progress in controlling the HIV epidemic, but as I've shown you, like in the general population, we've done a great job, but in key populations, we still have major challenges, and these need to be addressed if we are to meet the HIV UNAIDS targets. And we always talk about one size not fitting all, and which is completely relevant, and we say like Africa needs a program, Asia needs a program, India needs a program, but these data clearly highlight like even within countries, different cities or different key populations may need different programs. We can't take a program that we've tailored for MSM in India and try and give it to people who inject drugs. We can't take it from India and try and give it somewhere else. You really have to understand the characteristics and the demographics of the population you're working with. And before you translate programs into countries, please go and talk to those communities and try to figure out what's actually going on in those communities. And supply side, so just improving supply is not enough. You have to also generate demand. So this is something I think that's becoming more and more a theme globally, that just setting up these clinics and people will come. That was the old perception. Let's put up the clinics, people will come. But when you're talking about key populations, they're not going to come. Like you have to figure out what it is that's going to get them to come. For drug-using populations and for PVID, yes, opioid agonist therapy is a draw. It's going to bring them in there. But for men who have sex with men, we're still trying to figure out what is that hook that's going to get them to start coming into the clinic. And we are exploring electronic strategies, we're exploring WhatsApp, Facebook, all these different platforms. We've even been talking to MAC Cosmetics about setting up makeup hours, because a lot of the MSM whom we spoke to, I asked them, what would you want in your clinic? They said, if we can get a facial machine, we will come more often. So we said, or if we can get someone to come and do our makeup, we'll come more often. So we're trying to talk to them to see, does it actually work? There's no harm in trying it out. If it works, it works. If it doesn't work, then at least you've tried it and you know it doesn't work. And this is the same point I made earlier is we have to start thinking about integrating multiple programs. We are all stuck up in our own program. We'll say, I will only do HIV, I will only do TB, I will only do viral hepatitis. But I think especially in key populations where all these three problems are prevalent, the programs need to talk to each other, and you need to leverage upon each other's resources. For example, if you are looking at the Gene Expert platform, which is not available in the US, but available everywhere else in the world, the same equipment can be used for MDR-TB diagnosis, it can be used for HIV RNA, HBV DNA, HCV RNA. So with that one platform, the cost of the equipment could be subsidized across the 4 programs, but you could really get a lot more out of that platform, which currently doesn't happen. And the last thing I want to end with is we have little bits of information here and there, and we generally try to use that one bit of information we have to implement the program, but we really should be looking at gathering all the different sources of information, whether it's phylogenetics, whether it's like spatial distribution, whether it's what the communities want. Because most of the times I feel like communities are generally left out of the discussion about what they need, and most of the decisions come more from the central government or more from the state AIDS control society saying, this is what we need to give to the government, or this is what the communities need. But I think that two-way dialogue between the communities, the stakeholders, and leveraging all the different sources of information is critical if you really want to make inroads with any program globally. I have a lot of acknowledgements, especially all the research participants who generously participate in all these research studies globally, especially in India. We've recruited almost 70,000 participants across these different studies. Our teams from Hopkins, the YRG Care, and the National AIDS Control Organization who really have been very supportive of all our efforts in India, and our funding sources with NIDA, NIMH, Office of AIDS Research, ICMR, NACO, and the Elton John AIDS Foundation. Thank you.
We have plenty of time for questions. Thank you again, Dr. Solomon, for the wonderful talk. And you guys can see, just what the scale of Sunil's work is in India. It's not just affecting a handful of people. Yeah. So, anyways, any questions?
Hi, that was a great talk. Thanks. On the map that you showed with the concentration of MSM, and then the concentration of MSM that were HIV positive, and then viremic. In the area that was the most number of people that were viremic, what was it about that area? Is there a few clinics there? What do you think is contributing to that? And also, because you've presented the waves of RDS collection and how as you go further out in the waves, they're less connected. Were there people living in that area from the later waves? Does that have something to do with connection to the overall community?
So we didn't look at it whether it was the people from larger waves. So a couple of things. So when we did those maps, we had to collapse a couple of zones together because we wanted a minimum number of people living in each zone. And so we did collapse. We didn't look at the number of waves, but in terms of treatment and care centers, that wasn't the problem. There were actually treatment and care centers right around. We're still not sure what it was. We are going to be looking at it more in detail among some of the PIVOT communities. And we are building vans, which we're trying to outfit with like a confirmatory HIV testing and an outreach worker who, if we find someone who's positive, can link them to care straight away. So we're going to be using these maps to actually guide us as to where we should be going. So when we do that, we'll actually get a better sense of why there are certain pockets that are more, with more people who are viremic versus less people who are viremic.
Hi, thanks for a great talk. So I just wanted to ask about sort of how all of this amazing research has been presented to policymakers in general in India and then in the specific settings where you're working, and how the response may have been different across settings and kind of how you've managed that engagement process.
That's one of those questions you never know the right answers to. No, so it's been good because what we did was from the time we started the program, we've been working with the National AIDS Control Organization. So every time we do a survey, we give them all the data that we get from the survey. So like especially like our hepatitis C data has been quoted by the government several times, and I think it's probably among the only few community-based samples of the hepatitis C care continuum available in India. The state AIDS control societies actually have been working with us. They want us to do more. They don't realize the limitations of NIH funding. So we give them all the reports, and the ICC model, especially the integration of testing, the government of India is actually piloting it now in multiple settings. So they actually are trying to bring HIV counseling and testing integrated into all their opioid agonist therapy clinics across the country. The state AIDS control societies love the biometric model because they feel like that's a way for them to objectively track what is happening with the program, especially in TI NGOs, to rule out how many people are duplicates, how many people are counting the same people multiple times. So the 6 cities where we work, all the opioid agonist therapy centers, we run their biometric platform for them. So that's again something that they have adopted from the program which they use. There's a lot of these, and the National AIDS Control Organization has actually given us a grant now to run the exact same program among transgendered women in India. So there is some room for conversation and deliberation. They have this thing called a brown bag seminar in NACO where I first presented on the baseline findings, and then I presented on the network-based referrals for the RDS, which is again being piloted by the government of India in 2 settings. I think they're doing it in Mizoram and they're doing it in Vijayawada. So there definitely has been some adoption of certain things from the program, but overall we just don't know. The problem when we're working with the Indian government is ever since we started this program, we've gone through like 4 different people. And the person who was in charge of our TI program, we went from someone who was very supportive to someone who was completely non-supportive to again someone who's really supportive. So it's been a challenge trying to get things done, but it definitely has been a good experience working with them.
Thanks for your talk. The RDS was really impressive to me. I'm wondering if you are planning on comparing interventions that come from within the network to more of these geographic interventions, given the diversity that you saw in the geographic regions. So for instance, something that, maybe more influential norm type interventions through the network.
So if we're trying to leverage the RDS as an intervention?
Yeah.
So we are actually trying to do that right now. We've just submitted something where we're trying to see whether we could use RDS to find the people, but then use other proven interventions to get them virally suppressed. So because most of the interventions, if you look at the viral suppression interventions, they don't look at the first step, which is finding the person who's infected. And so you end up going only with people in care. So we're actually trying to use the RDS to find the people. So that would be almost like your first step, and then randomize them to interventions. And we're going to be comparing them to a condition where we don't use RDS in a geography and see how difficult is it or how different is it in terms of viral suppression if you used RDS versus you didn't use RDS, but all the other interventions remain the same.
That's great.
You guys have been doing a good job, and I see that the change. But I've been in the community for quite a long time. Have you guys ever thought of different programs or interventions like a needle exchange program, doing like site testing or mobile units, or something new you guys are planning on?
So we do have sit-in service programs in India. So sit-in service, opioid agonist therapy, both of them exist. We also have so we don't have medically supervised injection sites. That's what you're asking?
Yes.
So we don't have medically supervised injection sites. We have been talking to the National AIDS Control Organization to try and see if we can get naloxone. Because I think that's what I really want to try and somehow get into the Indian program is naloxone, because that really does make a big impact, but it's not available. But the other harm reduction interventions are available, and we do make them available.
So everyone has said what a nice presentation it is, but it really is. I mean, it's really impactful work and important work. So really enjoyed seeing that, Sunil. I'm not sure you mentioned this, but you've also been a leader in the MINMON study in the ACDG, the minimal monitoring study. And That's taking people, for those who don't know, who are diagnosed with hepatitis C, and giving them 12 weeks of therapy to take home, and then they take it with, so they don't have to continue to come into the research center or the clinical center and get seen periodically. And so it directly addresses an important aspect of dealing with these diseases in a resource-limited setting. So India has also been a leader in developing generic forms of antiretrovirals, and my question has to do with longer-acting therapies. You know, the photos you showed of areas where people are sharing needles. I wonder if what your thoughts are on the longer-acting HIV therapies, and if there's an opportunity there to try to administer those to people who are populations that are very difficult to access, and in order to try to reduce transmission, in the same vein of clean needle programs and so on.
No, I absolutely agree with you. I actually took that conclusion off. That's my conclusion tomorrow, so it's the same thing. I actually think there's a very distinct role for long-acting injectables, both for HIV, and if they can actually come up with some long-acting DAAs, I think that would be phenomenal. Because you could literally use RDS to bring them in and just give them a shot and get rid of it. And you'll be done with hepatitis C. And with HIV, we've done a lot of, so we have done a lot of directly observed therapy for hepatitis C. But in 2013, when the only pan-genotypics we had were SOF, PEG, and RIBA for 12 weeks, or you had to do SOF and RIBA for 24 weeks. And what people in the US and the European countries don't recognize is we have so much of viral hepatitis in India because of our love for injections. Right? Like that's the reason we have so much hep C and hepatitis B. And so what was amazing was almost everybody who got randomized to the SOF and RIBA arm were so upset that they were not getting injections. But everybody who got randomized to the SOF, PEG, and RIBA arm, who got that first PEG shot, came back the next day and was like, oh, I had a fever, the medicine's working. Right? And not one out of the people who got randomized to the PEG arm missed even one PEG dose. So they took all their 12 PEG shots. And 12 weeks of PEG really isn't that bad as compared to 24 or 48 weeks of PEG. So I think there definitely is a role for injectables. I think injectable treatment for HIV, injectable DAAs, I think will revolutionize the possibility of eradication. Like I think right now we're still talking about control, but as I showed you, it's going to be impossible with so much of migration and intercity clustering of epidemics that you really need something where you could start wiping it out one shot at a time. And the other thing I think that connects with what he was talking about is like not just harm reduction, but also injectable TAF or injectable TDF, because adherence is going to be a big challenge in this population, but we know where they are. And so if you can actually link it along with the OST program or link it with the syringe service program, you could be providing cleaner needles, but at the same time also protecting them. And I think at the same time, what we need to do is like continually monitor what's happening in the community. And beyond, again, from a programmatic perspective, it's very hard to justify spending money on something when you have so many other things to do. And so it is important to keep a track of what's happening in the community and say, well, if the threshold falls below X, then I'll stop doing the PrEP. But until then, I will give them all the PrEP, I'll give them all the harm reduction. And then I will just pull the PrEP or leave the harm reduction because we've brought the dose so low that the probability of them picking up infection is going to be even lower. So I think there definitely is a role. I just don't know when we are going to be ready for injectable DAAs or injectable ARTs.
I think we're going to stop there. Any other questions? You guys can catch up with Sunil afterwards. But can we just get one more hand for Dr. Solomon for this amazing talk?